I've been asked to bring a little update to the PIVOT trial. And as everyone knows, the PIVOT study was first published in 2012 in New England Journal of Medicine. And then very recently, I think it was last summer. Yeah, here it is, July 2017, it was published again. And so let's just start at the beginning. What was the purpose of PIVOT? It was defined in this way among men with screen-detected cancer in the early PSA era, and we'll get into the significance of that. Does the intention to treat with a radical prostatectomy, not does radical prostatectomy, reduce all-cause or prostate cancer mortality compared to observation? And it's important. This is observation, not watchful waiting, and not active surveillance. So this is from the original publication. You know, first off, only 77% had a radical prostatectomy. 15%, although they randomized to the radical prostatectomy, did not get it initially. On the other hand, of the men who randomized to observation, 10% got a radical prostatectomy, and 8% had other definitive therapies, usually radiation therapy afterwards. And you can see it took a median time of 2 years for that treatment to be administered. So it's not a perfect study, and no study is, of treatment A versus treatment B. There's these other considerations. Now, the only entry criteria that may get your attention is a PSA value of less than 50, and you had to have a predicted life expectancy, although there was no strict formula on how to predict that, of at least 10 years. Primary endpoint was all-cause mortality, not prostate cancer-specific mortality. And you can see the kinds of patients who were enrolled, about 67 years old. A third of the patients were African-American, but they otherwise were theoretically in pretty decent shape, and there was a good effort to include healthy patients. You can see the mean PSA was about 10. 10% of the patients had PSAs of over 20. And it's cut off on my slide, but I think something close to 20% of the patients were D'Amico high risk. Is that, how do I can't see the high risk group. Now, the one thing that I found interesting, I was one of the ABCs on the cause of death ascertainment committee of the PIVOT trial. And we got the blinded records of every man who died and had to determine if they definitely or probably did or did not die of prostate cancer. And as you can see, among the three of us, we agreed most of the time, but there was some of the time. And sometimes that was related to just the ambiguity of the clinical information and the fact that the vets seemed to move around and we didn't always have all the evidence that we would need to decide one way or another. But the other thing that came out is, you know, many of these patients had a death certificate, and the doctor signing the death certificate might have said, yeah, 46% of the men they thought died of prostate cancer. But when we reviewed it, at least 11 out of those 46 we thought died with prostate cancer, not of prostate cancer. And so when you're looking at some of these studies that ascertain the cause of death, yes or not, due to prostate cancer, it's probably worth a little effort to see how the endpoints committee adjudicated that. There are differences, for example, in that attribute between the SPG4, the PIVOT study, PLCO, and the ERSPC study. Now, the most recent iteration of the PIVOT study has a median of 12.7 years of follow-up, with the longest follow-up being about 20 years. The all-cause mortality at this point, about 2/3 of the patients are dead, and this is higher than was expected when the study was designed. And over the course of these median 12 years, only about 10% of the patients died of prostate cancer, notwithstanding that a considerable number of them had a PSA of over 20 and or were in D'Amico intermediate or high-risk disease. You can see the death from any cause and the death from prostate cancer curves. Here is the forest plot. All of the point estimates favor radical prostatectomy in terms of death from any cause. In some of the categories, PSA of over 10 and intermediate risk disease, there was a benefit to all-cause mortality from radical prostatectomy. If you looked at death from prostate cancer, again, the point estimates are all favoring radical prostatectomy, but the confidence intervals are large. And that's because there are only 10% of the patients had this particular endpoint. And so that's why all of these overlap one. Now, I want you to try to remember this because I'm going to show you the analogous diagram from the Protec trial later on. So this is the pivot study showing, that 80–85% of the patients get their radical prostatectomy early on, and some of them get other definitive treatments later on, but that in the observation group, only about 20–22% of the patients ever got definitive treatment, and that's now out to about 15 years of follow-up. Just keep that in mind. There's been some criticism, for example, that the radical prostatectomies done at the VA are not very good, and depending on how you look at this data, so if you look at the low-risk men who had a radical prostatectomy, the PSA failure rate at 15 years was only about 8 or 9%, a lot lower. So to me, that actually says the prostatectomies were probably pretty reasonable. The PSA failure rates for intermediate and high-risk patients, of course, were a lot higher. In terms of quality of life, not much difference between the radical prostatectomy and the observation groups, except as related to sexual functioning and pad usage. And you can see that the pad usage was probably a lot higher in this group, 40% of the patients at 10 years, than it would be in most radical prostatectomy series. So it's certainly true, like all randomized trials, there are a lot of criticisms you can come up with, but I think these are the three pivotal ones. The volunteers must have been sicker than met the eye because the death rate appeared to be higher than anticipated. There's no question this study was underpowered. It was designed for 2,000 patients. There were only 750, and you needed 1,500 or twice as many patients to have an 80% power. And there was a certain amount of crossover and non-compliance that further diluted the power estimate. Now, how does this compare to some of the other studies? This is the Bill Axelson study, the SPG4, that was published 3 or 4 years prior in the New England Journal of Medicine. A more mature study, not a bigger study, only 350 patients in each arm, so slightly smaller. But you can just see there's a lot of significant p-values in this trial. And you could see some of the graphs showing, radical prostatectomy for the entire group, statistically significantly fewer deaths compared to watchful waiting, much more prominent for the younger group of patients than it was for the older patients. Not much benefit for low-risk patients, excellent benefit for your intermediate risk patient. Again, not much benefit to your high-risk patients who had a radical prostatectomy. And you can see that fewer patients overall, even at 18 years follow-up in SPG4, were on hormonal therapy, and that's a good thing. Now, what's the other study that we can use to compare no treatment to definitive treatment? Well, that's the Protec trial that was published about 1.5 years ago. And look, we're all criticizing the pivot trial because only about 80% of the patients randomized to surgery got it. Well, that's the same in the Protec trial. That was a 3-arm study, but we'll forget about the radiation therapy group now. But notice in the pivot trial at 15 to 20 years, only about 20% of the patients had converted to aggressive intervention, but because the Protec Trial was an active surveillance study. You can see by, 8 years of follow-up, about half of the patients in the control arm or in the active monitoring group had received aggressive treatment. And in the Protec Trial, at 10 years of follow-up, almost nobody died of prostate cancer. There was more patients in the active monitoring group who had evidence of disease progression. And you can see that on this table here, where at the 10-year time point, 33 patients out of the 500 in active monitoring versus only 13 and 16 in the surgery and radiation therapy groups had clinically evident metastatic disease. So how do all these studies compare? And I'm glad Lori's in the room, and maybe we could just talk about this during the question and answer. Now, the SPG4 trial was done maybe 5-6 years prior to the PIVOT study. Lori's study started in the mid-1990s, as I have it, and the Protect study a few years after that. You can see the various interventions: radical prostatectomy versus watchful waiting versus observation. This is straight active surveillance. This is radical prostatectomy versus active surveillance. We have no idea how many biopsy cores were used to characterize the patients in SPG4. 90% of the patients in PIVOT had only a sextant biopsy, and the Protec trial called for 10 biopsy cores. So these patients, again, are probably better characterized than the patients in the PIVOT study. There are 695 randomized in SPG4, 731 in the PIVOT trial, but that represented only 15% of the patients who were invited to be randomized. We have no idea how many patients were invited here and didn't get randomized. Lori's study isn't really randomized. About 2/3 of the patients agreed to be randomized in Protect. You can see the mean age, 65, 67, 68, younger group of men in the Protect trial. You can see the percent Caucasian, I think, is probably 100%, but I actually couldn't find it. 62% in PIVOT, don't know about Lori's study. 99% white in the Protect trial. Only 15% of the patients in SPG4 had a PSA because this was clinically detected cancer. So only 11% of the patients were clinical stage T1C. In the PIVOT trial, about 50% of the patients were T1C with a mean PSA of 10. In Lori's study, about 80% were T1C and the mean PSA was 5. And that's very similar to the Protect trial in terms of mean PSA and clinical T1C. And you can see the percent that were Gleason 6 or less: 60, 74, 84, and 77. So there are, some differences in the clinical makeup. Now, this is there's probably longer follow-up, Lori, here, because I think I got these data from a 2014 publication of yours. But with PIVOT at 10 years, SPG4 at 10.8, Protect at 10, you can see that, well, actually, we're saying a lot of patients in PIVOT died prematurely. Well, 48% versus 45% in SPG4, but again, only 11% in the Protect study. And at 6 years, and you can correct me if I'm wrong, Lori, 15% in your study. Death from prostate cancer was actually highest in SPG4, and you would expect that because those were clinically detected cancers. The next highest group was in the PIVOT study, which was in the early PSA era and only patients with sextant biopsies, and much lower, prostate cancer death rate in Lori's study and in the Protect study, at about 10 years of follow-up. Now, at 20 years of follow-up, you can only compare PIVOT and SPG4. Again, we're deploring the very high death rate in the PIVOT study, but it's exactly the same as SPG4. The big difference is that, about 1/3 of the patients in SPG4 died of prostate cancer versus only about 10% in the PIVOT study. And I just think this exercise of just trying to compare the observation arms of these different studies is helpful because it shows how our characterization of the disease has changed over time, how that's a function of the number of biopsy cores, et cetera. And I just want to close with a slide or two that talks about variation in rates of radical prostatectomy in the United States. And these are among Medicare patients less than the age of 75. So this is a heat map. If you do a lot of radical prostatectomies, you're bright red to orange. So here we are in St. Louis, and I'm always encouraging the faculty to do radical prostatectomies. And then we've only got ourselves into the sort of second stratum of intensity of radical prostatectomy. So there's some room for us to do some more. But what I'm really proud of is that if you look at the Medicare radical prostatectomies we're doing, we are among the top 10, but only for patients who are very healthy, patients who have fewer than 2 chronic illnesses. On the other hand, some of these statistical areas that have very, very high rates of radical prostatectomy in Medicare beneficiaries are doing that because they're operating on patients who have a lot of chronic illnesses, the kinds of patients for whom radical prostatectomy is not apt to be beneficial. So what about PIVOT? Just in summary, surgery did not reduce mortality in men with low PSAs or low risk prostate cancer. And in conjunction with other trials, Lori's, for example, and others, this has been responsible for urologists' acceptance of active surveillance and observation for these patients. And I think one thing that's been lost in PIVOT is that this very low prostate cancer mortality in men with low-risk disease was observed despite the fact that the majority of these men were diagnosed on only a sextant biopsy, that repeat or extended saturation biopsy or MRI characterization or MRI targeted biopsies were not performed in the observation group. So thus, there's a considerable proportion of these low-risk men probably harbor Gleason 4 pattern 4 elements that were never diagnosed, and that this might call into question maybe the fact that we're over surveilling patients who are going under active surveillance because they have low risk prostate cancer discovered on a 12 core or even many more core biopsies of the prostate. I do think that PIVOT supports the SPG study that surgery is very likely to be beneficial for men with higher PSAs over 10, and at least for men who have intermediate risk disease. So that's what I got. Thanks very much for your attention.